Hello and welcome to the Patient Health Alliance series, NMOSD Master Class. We welcome everyone in attendance and remind that the Patient Health Alliance is a source of information and education for NMOSD and related conditions. The content of the following presentation is based entirely on published data or expert opinion. PHA is not a clinical provider and does not offer diagnostic, therapeutic, or clinical care recommendations or advice on personal health. All patients and caregivers are advised to consult with their healthcare team for specific information. The NMOSD Master Class has several overarching goals. First, it's a practical update of latest information on a specific topic. It's intended to illustrate key themes and clinical pearls related to that topic, and it's formatted to be inclusive of non-specialist audiences. And finally, there's an active question and answer discussion time to emphasize key points. My name is Michael Yeaman from UCLA, and I'm happy to be the moderator for this session. We are delighted to welcome Dr. Dean Wingerchuk as the featured speaker. Dr. Wingerchuk is professor and chair of neurology and the Eugene and Marcia Applebaum Professor of Neurosciences at the Mayo Clinic in Scottsdale, Arizona. His topic today is an update on diagnostic criteria for NMOSD.
Well, thank you very much, Michael. It's a pleasure to be with you and all those participating. My task today is to provide an update on neuromyelitis optica spectrum disease, NMOSD, diagnostic criteria. So my objectives are as follows. I'll provide an update on what's called the IPND, the International Panel for NMO Diagnosis, and its consensus activities towards revisions to diagnostic criteria last published in 2015. I'll also describe revised criteria for seropositive NMO spectrum disease and discuss the evolving classification of seropositive and seronegative patients. These are my disclosures. The IPND is a panel that was first convened in approximately 2012 and worked to publish the 2015 iteration of diagnostic criteria for NMO spectrum disorders. IPND has been updated for this project with more than 130 members across the world, a much larger consensus project than the 2015 criteria effort. We started with a survey supported by the Guthrie-Jackson Charitable Foundation and its International Clinical Consortium, or ICC, and that survey was done at the ECTRIMS meeting in Amsterdam in 2022, where there was very strong endorsement of a new IPND effort. The rationale for this was largely threefold. The first was to address scientific advances that have occurred over the last decade. Second was to acknowledge the emergence and subsequent validation of myelin oligodendrocyte glycoprotein-associated disease, or MOGAD, and the need to address so-called seronegative NMOSD. This is the organizational structure of the current IPND panel called IPND 2025. And it was first convened in 2023, and it consists of a number of different arms. At its core is a steering committee of 26 members, and it's supported by an additional 43 focus area members. Those focus area members are grouped into 6 fields relevant to the clinical science and biology of this disease. Their focus areas: 1, clinical; 2, serology; 3, imaging; 4, biomarkers; 5, nosology, or nomenclature; and 6, focusing on seronegative patients. We have global representation with members from more than 35 different countries. And the goal here was to be inclusive, evidence-based, consensus-driven, and forward-looking, building both the clinical criteria in an updated fashion, but also a future research agenda. You can see in this schema diagrammed here that the steering committee was supported by a number of special advisors and international consensus faculty, which were derived from the Guthrie-Jackson Foundation ICC membership predominantly. There were two key objectives for this project. The first was to refresh diagnostic criteria and clinical guidance for NMOSD with aquaporin 4 antibodies, or seropositive disease. And second, to update the classification, diagnostic criteria, and nomenclature for both seropositive and seronegative patient groups. The methodology included a systematic literature search, actually multiple searches, looking at the literature published since the 2015 criteria emerged, a synthesis of evidence after extraction of data and its evaluation, aided by a tool called Covidence, and then the use of a consensus process, a modified Delphi approach, and RAND UCLA appropriateness methodology. So the top line results thus far are as follows. First, I'll present updates to the seropositive criteria, and then secondly, where we are currently with classification and nomenclature. This summary was in large part presented at ECTRIMS in September 2025 in Barcelona. First, NMOSD with aquaporin 4 IgG, or seropositive NMO spectrum disease. You'll hear in a few moments when I talk about nosology and nomenclature that the seropositive state is now referred to as a disease. So NMO spectrum disease has now supplanted NMO spectrum disorder. It's a preview. Under the umbrella of seropositive disease, we updated a number of things with regards to clinical practice, including the clinical syndromes and signs associated with the aquaporin 4 antibody, guidance on serology, neuroimaging results, and biomarkers. In the newest revision, we've added an acute brainstem or cerebellar syndrome to the neuroanatomic regions that can be affected in this disease. This is to incorporate evidence that shows that cerebellar ataxia, sometimes alone, but often in combination with other brainstem and connecting signs and MRI lesions, is a core part of seropositive NMOSD. In addition to that, the committee wanted to put a spotlight on the relative importance increased in NMOSD of the recognition of paroxysmal tonic spasms and neuropathic itching as features that, while not pathognomonic, are particularly suggestive of NMOSD, especially when they occur in the context of an acute, longitudinally extensive transverse myelitis syndrome. The group also reaffirmed that the diagnostic criteria for seropositive disease may be applied equally in both adults and children. A few comments on serology. First of all, the committee endorsed that serum is the recommended testing sample. Although CSF can be used to test for aquaporin 4 antibodies, typically it is positive only when serum titers are very high. So it is really serum that one wants to test. Secondly, the guidance is to always obtain the best available assay. And there was consensus endorsement by the panel that a live cell-based assay for AQP4 IgG is the reference standard. That's the gold standard. We recognize that this is not available everywhere. Where one has access to a fixed cell-based assay, A positive result does not require live cell-based assay confirmation. So in a positive state, a fixed and live cell-based assay, fixed or live cell-based assay will suffice. ELISA tests are now not recommended, though the committee does recognize that in some areas of the world that is still the best available test. If used, the results should be interpreted carefully and ideally confirmed at some point by a cell-based assay. Finally, the group emphasized guidance when there is a clinical suspicion for NMOSD, but if initial testing is negative, especially if that initial assay was not a live cell-based assay, or the sample was collected during a period of remission. Titers in general tend to be higher during relapses, and so that is actually the best time to test. And third, a sample that is collected after a potentially interfering treatment. For example, a sample collected within a few days of plasma exchange. That might be one situation in which the confounding effects of the treatment render the study negative when it's true positive. So retesting is recommended in these situations. Third, updates on imaging. First, brain and entire spinal cord imaging is recommended in all patients with suspected NMOSD. Orbital imaging is recommended with specific sequences and contrast when there is suspected acute optic neuritis. OCT, ocular coherence tomography, and visual evoked potentials can be used to confirm optic nerve abnormalities if needed, similar to MS criteria. The group also points towards some updated NMOSD MRI patterns. Here are some examples. I mentioned earlier that cerebellar or cerebellum brainstem events have been added to the clinical syndromes associated as core clinical syndromes with this disease. Panel A in the upper left shows the arrows showing a lesion in the cerebellum in the dentate region, which has a high propensity for being involved in seropositive NMOSD. Panels B and C show lesions around the fourth and third ventricles, respectively. The three arrows in panel D outline what's called linear ependymal enhancement on a coronal cerebral enhanced MRI, quite typical for seropositive disease. And the two panels E1 and E2 show sagittal and axial imaging, respectively, outlining so-called bright spotty lesions in the spinal cord. So these are often foci of very bright T2 signals within a longitudinally extensive transverse myelitis lesion. Focus area 4 addressed biomarkers. In summary, for the purposes of diagnosis, serum aquaporin 4 IgG is the only required diagnostic biomarker. There was quite a bit of debate in the panel about the potential utility of either serum or CSF glial fibrillary acidic protein, or GFAP, with more than half of panelists considering it a promising marker, but for diagnosis, it was felt that more evidence was needed. In fact, it was felt that this particular protein, GFAP, is a better marker of disease activity or relapse than it is for diagnosis. Moreover, routine serum and CSF GFAP measurement is not recommended to support diagnosis. And the same can be said for NFL, or neurofilament light chain, also not recommended to support diagnosis. Now on to classification. If we look back to the 2015 criteria, the current ones used for both diagnosis and research, we can see in the so-called universe of CNS inflammatory conditions, there's this umbrella term of NMO spectrum disorders, or NMOSD. And under that umbrella, there was seropositive NMOSD, so NMOSD with aquaporin 4 IgG, and seronegative or without aquaporin 4 IgG. And these patients, as defined in 2015, the seronegative ones, were essentially meant to be a phenocopy or a mirror image. They were patients who had typically combinations of findings such as optic neuritis and longitudinally extensive transverse myelitis. No better explanation for the clinical syndrome, and they look like they should be seropositive for aquaporin for IgG, but they're not. And indeed, they would be negative for other testing, including MOG antibodies. What actually happened over the last 10 years is, first of all, the emergence of MOG-associated disease, or MOGAD, which the current IPND panel has removed from or separated from NMO spectrum disorders, or NMOSD. And the term NMOSD has largely been applied to aquaporin 4 positive or so-called double seronegative patients, patients who are negative for both aquaporin 4 and MOG antibodies. And on the far right here, you see other seronegative syndromes. These are partial syndromes or syndromes that resemble, to some degree, aquaporin 4 positive disease, but are incomplete. A good example of this would be recurrent isolated longitudinally extensive transverse myelitis. So up until recently, this was sort of the classification system that many people were using. We addressed this in the panel by approaching classification quite systematically. And we looked at it from the standpoint of disease versus syndrome. A disease is an involuntary physiological or biological illness that typically has some underlying cause, and it may indeed be a cause that's well known or well understood. Note that in MOGAD, the D stands for disease. And in NMOSD, given the fact that we know the target antigen, aquaporin 4, we have an antibody, understand the mechanisms of how that antibody is likely pathogenic for this disease, and understand a lot about the pathobiology of how the interaction between the antibody and its antigen causes neurologic damage. For all those reasons, the panel felt that NMOSD meets the criteria for a disease and proposed that we change the term NMOSD, not the acronym, but the term, to NMO spectrum disease. A syndrome, on the other hand, is a constellation of symptoms and signs that occur together and may co-vary over time. And this raises the question in the 2015 criteria, what is seronegative NMOSD? And what have we learned in the last 10 years? Well, one possibility, of course, is that these patients, some of them at least, are false negative assay results. So they're truly NMOSD, but for some reason we cannot detect the antibody. The other possibility is that they're a phenocopy. They look very strongly like a mirror image of aquaporin 4 positive disease, but in fact have a different and as of yet unidentified cause. So one way we looked at these seronegative or double seronegative patients was to evaluate the literature over the last 10 years to determine whether there was evidence that these patients or a subset of these patients actually had the same biology and the same immunopathology as seropositive disease. So are they, in fact, the same diseases biologically? We looked at 3 lines of evidence: pathology, biomarkers, and clinical trial data. And the bottom line is, after extensive review of the evidence, that seronegative or so-called double seronegative patients have not convincingly been shown, either as a whole or in subsets, to have the same pathobiology as NMOSD with aquaporin 4 antibodies. From the pathology standpoint, there are no cases published that we could detect or identify in which a seronegative patient tested with valid reference standard assays showed the kind of immunopathology that is seen in patients with seropositive disease. We looked at biomarkers, especially GFAP, NFL, interleukin-6, and complement proteins. And although there's overlap to some degree, a variable degree, the literature suggests that the biomarker profiles between seropositive and these so-called double seronegative patients are in fact different. And then finally, clinical trial data, and especially data derived from studies of interleukin-6 targeting drugs such as satralizumab, where there were patients that were enrolled in trials, either seronegative or seropositive, and found that the drug positively benefited the seropositive patients, but did not benefit the seronegative patients, suggesting that the underlying biology, in fact, may be different. So the implications of this are that there are patients with clinical and MRI phenotypes that either very closely mimic or resemble seropositive NMOSD who test negative for both aquaporin 4 and MOG antibodies. And we would say that these patients have a clinical syndrome rather than a disease. I'll next show you some summary guidance in one very busy slide that I'm going to show in two parts, which is a diagnostic algorithm for aquaporin 4 testing to try to help a clinician divide patients into aquaporin 4 positive NMO spectrum disease and separate that from the seronegative syndromes. So beginning at the top in yellow, if a patient presents with a core clinical presentation of NMOSD, such as optic neuritis, longitudinally extensive transverse myelitis, area postrema syndrome, or any of the other less common variants, the first test will be a serum aquaporin 4 antibody assay. Now, in this instance, we're looking at a live cell-based assay. So this clinician has access to the reference standard, the best available test. If that assay is positive, then the diagnosis is confirmed NMOSD or NMO spectrum disease with aquaporin 4 antibodies. If, on the other hand, that testing is negative, then we would indicate that this is a confirmed seronegative clinical NMO syndrome, not the disease, but a syndrome. We also would have to evaluate, though, carefully the clinical context, the potential differential diagnosis, and any potential confounders. As I mentioned earlier, testing during remission or testing in the presence of therapies that might interfere with a positive result. And if either of those are present, then retesting again at a future date with a live cell-based assay and reassessing the diagnosis is indicated. Use of the live cell-based assay gives the highest degree of diagnostic accuracy and is the cleanest, if you will, of all of the options that I'll show. I think you'll agree as I show the rest of this algorithm, it does look somewhat more complicated. But really, to simplify it, I would just state the following. If using anything other than the live cell-based assay, one needs to carefully consider the clinical context, the pretest probability of NMO, the differential diagnosis, and any potential confounders. I mentioned earlier that a fixed cell-based assay, when positive in the right context, is essentially equivalent to a live cell-based assay for a positive result. A negative result, however, is less clear. If one uses another assay like an ELISA, both the sensitivity and the specificity are significantly lower than for the live cell-based assay. And one needs to be very cautious in interpreting those tests. And what the algorithm is really showing here is a reassessment again of the clinical context, potential confounders, and emphasizing retesting if suspicion is high, and again, trying to access the assay with the greatest diagnostic accuracy, striving, if possible, for a live cell-based assay. Back to classification, where have we gotten with consensus? Well, the panel thus far has concluded the following. In the universe of CNS inflammatory demyelinating presentations, we can divide disorders into diseases, which are seropositive, and syndromes, which are either seronegative or perhaps not serotested. Under the disease category, the IPND has now clearly stated that MOGAD resides separately and is distinct from aquaporin 4 positive NMO spectrum disease. They're both labeled diseases. They both have associated serum biomarkers, but they are distinct from each other. MOGAD is not a subset of NMOSD. Under the syndromes, we can consider a couple of different scenarios. First of all, there are isolated phenotypes. These are, you might say, pieces of an NMO puzzle. Perhaps it's as simple as a single event of optic neuritis or relapsing isolated optic neuritis, or the same scenario for myelitis. Those kinds of isolated phenotypes are descriptive syndromes. You can also imagine a whole host of multifocal phenotypes. A classic DeVix presentation is one example where you would have a combination of optic neuritis and longitudinally extensive transverse myelitis. But you can imagine a large number of potential combinations that you might list as descriptive syndromes, syndrome A, B, C, etc. And of those, we may take a subset and group them under an umbrella term such as NMO syndrome or NMO spectrum syndromes. And this is the area that the IPND group is now continuing to work on for consensus, is to determine the final classification, nomenclature, and grouping of these different disorders. We think this is important to enhance both clinical and research communication for the future. So in summary, the update is as follows. Our modern classification scheme is meant to distinguish diseases more clearly from syndromes. NMOSD classification has been revised to separate seropositive NMO spectrum disease from MOGAD, and importantly, separate both of those from seronegative or sero-untested clinical syndromes. NMOSD remains the acronym, but is now NMO spectrum disease, and that is exclusive to the seropositive state associated with aquaporin 4 antibodies. And we have refreshed NMOSD criteria for seropositive patients. Cerebellar syndromes have been added, new guidance on serology and imaging, live CBA is the reference standard, and biomarkers are continuing to be investigated. We have remaining consensus work to finalize criteria and grouping for seronegative syndromes, to finalize nomenclature, to complete a prospectus. So this is an outline of the science that we should be looking out for on near and potentially far horizons, and validation strategies. What will we do in the future to clarify the diagnosis for this puzzling group of patients that remains, these seronegative syndromes? That's the update at this point on the IPND consensus criteria for NMOSD and seronegative syndromes. Thank you for your attention today. I'd like to acknowledge all of the participants in the international panel for NMOSD diagnosis, all of the members of the steering committee, the focus area leaders, special advisors, international consensus faculty, and the support from the Guthrie-Jackson Charitable Foundation, without whom we couldn't have completed this project. Thank you.
Dean, thank you so much for that excellent overview of the updates on the diagnostic criteria consensus process. We really appreciate all the leadership you've provided and the work of the IPND group overall. Why don't we take a little time, Dean, to talk about some questions that are often raised, but that might be helpful to clarify a little bit. So you mentioned that the process has been evidence-based and essentially derived from work done by members of the IPND regarding literature searches and case reviews, et cetera. So can you comment on the strength of the evidence that suggests that NMOSD with aquaporin 4 or NMOSD disease is justified to be separately classified versus seronegative syndromes?
Yeah, that's an excellent question, Michael. So I think the evidence is variable in strength. In a sense, you could look to the third category that I presented, the clinical trial evidence, as perhaps the most rigorous because it occurred in the context of a true randomized controlled trial and demonstrated that when subjects were enrolled, for example, to the satralizumab studies of NMOSD, which allowed for seropositive and seronegative patients as defined by the 2015 criteria, and everything else about that, about those therapeutic trials were the same, but the results of the trials were distinctly different. So clinical benefit of satralizumab for seropositive NMOSD, but no benefit seen for seronegative. On the other hand, the first area that I pointed to was pathology. And arguably, that could be the gold standard, recognizing that the immunopathology of NMOSD, seropositive NMO spectrum disease, is quite distinct, with findings that really do separate it from, for example, multiple sclerosis, and even with limited evidence, MOGAD. We found very few publications that had autopsy or biopsy material from patients tested and found to be seronegative, but the panel's review showed that the pathology of those patients was not in keeping with seropositive disease. So that strength of evidence is, I think, strong for the couple of patients that are in the literature, but not very strong from an actual volume of evidence standpoint. What's really missing outside of the clinical trials is carefully curated, prospectively evaluated patients who contribute lots of information, including biomarkers, therapeutic response. Ultimately, of course, you would like to see pathology if that was possible, knowing that it's often not. But much of what we looked at, were the results of retrospective studies. But in some, the results were consistent, and that is, they really don't support that these seronegative patients or subsets of them have seropositive disease.
Understood, Dean. Thank you. And in light of those sets of evidence, how much will the revised criteria change clinical diagnosis for aquaporin 4 positive NMO spectrum disease?
Yeah, I don't think that the refresh of the diagnostic criteria for seropositive patients is going to change things all that much, partly because the 2015 criteria are actually pretty good, we thought, for diagnosis. They're anchored to, they require the detection of the antibody. We do think that updating some of the serological guidance and interpretation of MRI patterns that are suggestive of and consistent with seropositive disease will be helpful. Maybe that will help us ascertain some more patients that are not currently recognized. But I think that incremental change is likely to be is likely to be modest. I would add too that the criteria change for seropositive, this refresh is not going to remove the diagnosis for anybody who previously was diagnosed with seropositive disease, as long as they have an assay result that is valid and positive.
On that note, Dean, the proposed revisions to the criteria for aquaporin 4 positive NMO spectrum disease include live cell-based assay as being the reference standard. What if that's not available for a clinician and their evaluation?
Yeah, excellent question, Michael, and one that's often asked because live cell-based assays are rather limited in their availability throughout the world. But the panel wanted to do a few things. First of all, they wanted to emphasize to always get the best available test, to not settle for a certainly an untested state, but also an assay that is not optimal and especially if it's negative in a patient for whom a clinician has a high degree of suspicion of NMOSD. That said, as I mentioned earlier, the sensitivity of a fixed cell-based assay, so when it's positive in disease, is very strong. For fixed cell-based assay, similar to a live cell-based assay, ELISA is a significant step down, yet we have to remember that in the appropriate clinical context, a convincingly positive aquaporin 4 ELISA test, high titer, that is likely the right diagnosis. And in fact, if we think about our recent clinical trials that led to approved therapies, in the large majority, if not almost all of those patients, their diagnosis was confirmed by an ELISA test. But the ELISA does have clear false negatives and some false positives that need careful clinical context and examination. And that's the other area that the panel wanted to emphasize, is always going back to the clinical and imaging presentation.
Excellent, Dean. And we know that there are a number of new types of assays that are being evaluated that might be as good as live cell-based assay, et cetera. So we'll look for those. But on that note of sort of forward-looking biomarkers, the panel did not find any other biomarkers other than aquaporin 4 antibody as essential for diagnosis of aquaporin 4 positive NMO spectrum disease. What do you see as the future for biomarker discovery, either in seropositive or seronegative conditions?
So, yeah, a few things I guess I would look at personally. Number one is aquaporin 4 antibodies. Those assays are the cell-based assays have an extraordinarily high sensitivity and specificity. And so one doesn't really need any additional biomarker support for diagnosis. You could think that in the seronegative state, that identification of biomarkers, and here's where GFAP was of significant interest, for example, as a marker of astrocyte injury, and the astrocytes being the primary target, and cell expressing aquaporin 4, that the question was raised, could GFAP measured in serum or CSF serve as a diagnostic marker for patients with seronegative disease, seronegative syndromes, I should say? Well, so far the answer seems to be no, but I think it's still uncertain as to whether or not there is a subgroup of patients out there who test seronegative and are really false negatives, and for which a very high serum GFAP might be a marker that those patients need to be retested in the future. They're a high-risk patient. So that's one possibility. I think stratification of those kinds of biomarkers might allow us to also identify subgroups of seronegative patients that could enhance future antibody discoveries. So just like we found aquaporin 4 and now MOG antibodies, others will come. We might find those in undifferentiated patient sets, or we might find them by hunting for them in patients that have specific phenotypes or grouped phenotypes or have specific biomarker profiles. And then beyond diagnosis, I see a lot of room for biomarkers to help us with therapy, relapse prediction, and a whole series of other questions.
Thanks a lot, Dean. Maybe just one last question. Big picture, a lot of work has gone into this. As you said, the IPND 2015 criteria were actually quite excellent, and the 2025 update provides even further resolution. But what do you think the benefits overall of the new classification schema might be with respect to seropositive disease and seronegative syndromes?
Well, I think many of us are hoping for clarity, a classification system and its use to enhance clarity of clinical and research communication, publication, et cetera. I think one of the areas of concern has been that although we developed diagnostic criteria for seronegative NMOSD in 2015 and made them look like seropositive patients without the antibody, the literature is really kind of unclear and messy about what types of patients actually are in this heterogeneous group. There's not a lot of information in many of the publications that gives you a lot of comfort as to exactly what types of patients are being described and how intensively they were investigated. So we think the classification syndrome emphasizing the distinction between disease and syndrome is important. It really means it's meant to clearly demonstrate that the syndromes are unknowns, that they need careful clinical investigation, and they need a research agenda to figure out exactly what they are. And that requires very clear communication. I think within the community, there are, just like there always is, there are lumpers and splitters, people who would like to take that seronegative group and divide them into many little categories, and others who would like to lump them into one or two categories. And we're trying to accommodate that to the degree that we can achieve some consensus to allow the field to move forward in a way that gets us further along in the next 10 years than we got with seronegatives between 2015 and 2025.
So then, Dean, kind of coming back to the first question of evidence, where do you see the seronegative biomarker story evolving to be evidence-based disease or syndrome differentiating?
Well, I think it's one wonders, are we likely to find another biomarker in the future with the incredible sensitivity and specificity of aquaporin 4? It's really an outlier in immunology and neuroimmunology. And so it's more likely that we're going to find antibodies, I think, that are more like MOG antibodies that are challenging to develop assays for, that have more frequent false positives and sometimes false negatives, maybe even disappear like MOG antibodies. And so for all of those reasons, we're going to need, I think, a common and consistent clinical and imaging language to define the phenotypes, and then standards for documenting and reporting biomarker profiles that help us parcel these patients into different groups so that we really understand whether we're dealing with pathogenic antibodies that identify new diseases or bystander markers of syndromes. I think we're just scratching the surface of that. But the better we can define a framework going forward and use it consistently and insist that people publish using consistent nomenclature and techniques, I think the further ahead we'll be.
Dean, thank you very much, as always, for your clear thinking on this complicated but very important topic and your ongoing leadership to develop consensus. Thank you so much.
Thank you, Michael. It's a pleasure being with you.
We hope this presentation has been helpful. To access this session and the other sessions in the Masterclass series, please visit the Patient Health Alliance website using the QR code shown here. The website link directly to the session is also shown below. We want to take a moment and thank Alexion as the sponsor by way of an educational grant for this Masterclass session. Once again, on behalf of the Patient Health Alliance, thank you so much for your attendance, and we hope everyone is doing well.